This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. Alright, this is going to be pulseless electrical activity. And in this section we're going to talk a little bit about pathophysiology, pharmacology review, how to treat it, and then we're going to do a quick scenario. Pathophys of PEA is pretty much in its causes. So the ones that are outside here that have an M on them are all mechanical causes. Example of this, hypovolemia, if you bleed out, don't have enough to generate cardiac output. It may look great on the monitor, but may not be able to generate you an adequate amount of cardiac output. Hypoxia, another cause, hydrogen ion or acidosis. Hypo or hyperkalemia, hypothermia, toxins, a PE or a thrombosis, pulmonary style, and then a thrombosis coronary style or a massive heart attack. Now, in these causes, the ones with the M's on them are caused from a mechanical source. So in hypovolemia, you bleed out enough to where the heart's doing its own thing, it's generating electricity, we can see it on the monitor, but still do not have the ability to generate a cardiac output. In hypoxia occurs, the muscle cells go into an anaerobic state of metabolism, they go into cellular bankruptcy and do not have the ability to provide a cardiac output. The two differences between these is in the PEA case, hypovolemia would give you a narrow complex if it's seen very early, and hypoxia would give you a wide complex PEA. We're going to run both scenarios in this scenario set. So again, the ones with the M's on them are mechanical, and all the mechanical causes will give you narrow complex PEA. All of the other ones that are listed will give you a wide complex PEA. And so on. So in this here, if the person did not have any pulse whatsoever, no pulse, this is nice and narrow. This looks like it should be providing ample cardiac output, but is not. Now, the reason this is problematic is this is probably going to be caused from a mechanical source. A quick acronym to remember this is going to be CHET. Cardiac tamponade, hypovolemia, embolism, pulmonary style, and a tension pneumothorax. Now, each one of these, cardiac tamponade, bleeds around the pericardial sac, collapses the chambers, it looks great on the monitor but has no cardiac output. Hypovolemia, you bleed to the point to where you have no cardiac output. Embolism essentially occludes the pulmonary artery. No more blood gets circulated through the pulmonary trunk. No more cardiac output. And then a tension pneumothorax, drop in a lung, mediastinal shift, collapsing of all four chambers, and no cardiac output. If you catch each of those early enough, those will form a narrow complex PEA. This is wide complex PEA. If this has no pulse, again, this would probably be from an electrophysiological cause. And the acronym for that is 4-HDOA. Hyperkalemia, hypokalemia, hypothermia, hypoxia, drug overdose or toxins, and then acidosis. Each one of these will mash out your QRS and make it to the point to where it cannot generate a cardiac output. Examples: too much potassium on the outside of the cell, heart doesn't have the ability to beat, widens out the QRS and cardiac output goes away. Not enough potassium, same thing, does not have the ability to generate an action potential and cardiac output goes away. Hypothermia, we freeze you, things slow down, cardiac output's reduced, and it looks great on the monitor, but it is not providing ample enough blood supply to provide a pulse. Hypoxia, anaerobic state of metabolism for the muscle cells, no generation of cardiac output, and pulse goes away. Drug overdose or toxins, more specifically a TCA, tricyclic antidepressant. A beta blocker would do a pretty good job of this, and so would a calcium channel blocker. Any of those would affect the myocardial tissue and reduce myocardial activity enough to where it might reduce cardiac output enough to where you would not have a pulse. And then last but not least, acidosis. If we change our pH from 7.35 to 7.45, do not have the ability to live outside of this physiological environment here. Things go bad, proteins denature, and things don't work like you think they should. The medications we're going to review here in the pharmacology review are going to be epinephrine and sodium bicarbonate. Epinephrine is our primary drug for this, and it's the only drug that we're going to push continuously during a PEA event. It pretty much works directly on alpha and beta receptor sites. It is a synthetic catecholamine. We use it, or the primary indication is for a pulseless arrest. The adult dose on this is going to be 1 milligram every 3 to 5 minutes. And the absolute contraindication, there's going to be none in the areas listed above, and that area is going to be a pulseless arrest. Sodium bicarbonate, alkalizer, primary indications is going to be for acidosis, and it's also an antidote. This is the antidote for tricyclic antidepressants. The adult dose is 1 milliequivalent per kilogram, and the absolute contraindication is renal failure. However, if you have a patient that you think that is acidic and in renal failure, please adjust accordingly and give them a loading dose of sodium bicarbonate. They can work out the sodium levels later on whenever they actually get them to the emergency room and they get dialysis. The treatment of this is we're going to do this in the form of CAB, or start CPR, give oxygen, and attach to monitor. We're going to check for responsiveness, initiate chest compressions, and then initiate a BLS airway and be sure that breathing is going on. This is going to be done in a fashion of 30, well, let me erase this, I'm outside of my screen here. CAB will be done in BLS mode at a ratio of 30 to 2, 30 compressions to 2 ventilations. We're going to do things in 2-minute cycles and check for pulses in between, no longer than 10 seconds. We should initiate an ALS bridge in these 2-minute cycles, IV-IO access. Epinephrine, once it's started, is given every 3 to 5 minutes as long as the patient is pulseless. We should consider an advanced airway as far as an ET tube, and capnographic waveform is important in when placing an ET tube. And we should consider our causes. Our causes, if we can treat them and get ahead of the physiology, is what will correct a pulseless electrical activity or a PEA. The scenario for your first scenario, scenario 1 here, is a 25-year-old male involved in a motor vehicle accident. This guy has Ford imprinted in reverse on his chest, no respirations, no pulse, and the EKG shows this. Start CAB or BLS at 30 to 2, 100 compressions per minute.
Obtain a sample OPQRST history. Start considering your causes, your H's and G's or Chet4-HDOA. Intubate and start an IV or IO in your patient. Administer epinephrine 1 mg every 3 to 5 minutes. Continue treatment and transport to the appropriate facility.